Hello everyone. Today's session is Drugs for Gout. This session is applicable for students of pharmacology under the CBME curriculum. The learning objectives for today's session are as follows. Classification of drugs for gout, drugs used for acute gout, drugs used for chronic gout. Now, these are the areas from where you can expect questions in the pharmacology examination. So before we go into the learning objectives, we'll try to understand the occurrence of gout very briefly. So you all know from the first year that gout is a disorder of purine metabolism, which is characterized by hyperuricemia. Now, the hyperuricemia in gout can be either due to an increased synthesis of uric acid, or it could be because of decreased excretion of uric acid in the urine. So let's have a recap of uric acid metabolism. So you have all seen this in your first year, how the uric acid is produced in our body. So the purines are changed to hypoxanthine. Hypoxanthine is converted or metabolized to xanthine, and xanthine gets metabolized to uric acid by the enzyme xanthine oxidase. This uric acid is quite low water solubility and is excreted by kidney. So the hyperuricemia can result either because of the increased synthesis of uric acid because of this particular pathway, or it can be because of decreased excretion in the urine. Now, the gout can be either acute gout, and the clinical features of the acute gout include severe inflammation in small joints. And the joint which is mostly affected is the metatarsalophalangeal joint of the great toe. And the patient usually presents with swollen, red, and painful joint that is called as podagra. The main pathology that is there in acute gout is severe inflammation. On the other hand, chronic gout occurs because of long-standing hyperuricemia. And in contrast to the acute episodes of gout, the chronic gout manifests with a hard, painless deposit of uric acid crystals under the skin of pinna, eyelids, nose, joints, and tendons, which is referred to as tophi. Now, this tophi, when it is extensive, it can damage the joints and can result in chronic arthritis. Chronic gout also results in urate stones developing in kidney, which can eventually lead to kidney damage. Now, let us see how the inflammation occurs in gout. So, as I said, there is an excessive uric acid level in gout, and the urate crystals, because they are in excess, they get deposited in the synovial fluid. The synovial fluid engulfs the urate crystals and releases inflammatory mediators, which start attracting the WBC into the joint. Now, the WBC, once it is there in the joint, it starts releasing a glycoprotein, which aggravates the inflammation by increasing the lactic acid production from the inflammatory cells, which decreases the local pH and causes more urate crystals to precipitate in the joint. Now, the glycoprotein released by the WBC also causes the release of lysosomal enzymes, which cause further joint destruction. This is the pathophysiology of gout. Now, let us have a look at something which is called as secondary hyperuricemia. Now, in secondary hyperuricemia, it can result either because of diseases like leukemia, lymphomas, and polycythemia when it is treated with chemotherapy or radiation. Because whenever the leukemias or lymphomas are treated with chemotherapy, it causes enhanced nucleic acid metabolism in the cancer cells, which leads to increased uric acid production. Some of the drugs like the thiazides, furosemides, pyrazinamide, ethambutol can cause secondary hyperuricemia. Now, we come to the main learning objectives of today's session. The first one being the classification of drugs for gout. So, we'll classify the drugs for gout as drugs used for acute gout and the drugs used for chronic gout. So let's have a look at the drugs which are used for acute gout. Now, what you have to remember here is that the drugs which are used for acute gout are the drugs that decrease pain and inflammation. These drugs do not decrease the progression of the disease. That is, they are not involved in the decrease synthesis of the uric acid or increase excretion of the uric acid. So they are mainly concerned with the symptomatic management of the gout. So these include NSAIDs, that is a non-steroidal anti-inflammatory drugs, colchicine, and corticosteroids. The second part of the classification includes the drugs which are used for chronic gout, and these drugs are also used for secondary hyperuricemia. Now, these are the drugs that lower the blood uric acid levels either by decreasing the synthesis of the uric acid or by increasing the excretion of uric acid. This involves two types of drugs. One is called as a synthesis inhibitors, and the principal drug under this is allopurinol. You can also remember the other drugs, that is febuxostat and rasburicase. But the main drug that you have to remember here is allopurinol. The other class is the uricosurics, and under this, the main drug is probenecid. You can also remember another example, that is sulfenpyrazone. Now, let us take each class one by one. So, we first take up the drugs for acute gout, and the foremost drugs in this category are the NSAIDs. So you already know that they are potent analgesics and anti-inflammatory drugs. And in the gout, they mainly inhibit the chemotactic migration of WBC into the inflamed joint and the further events, that is the production of glycoproteins, the decrease in the local pH, and the production of lysosomal enzymes, which we already discussed in the previous slide. Now, the examples of NSAIDs which can be used for gout include indomethacin, naproxen, piroxicam, diclofenac, etoricoxib. Now, these are usually started at a very high dose when there is a severe pain and redness to the swelling. And usually when we use these drugs, the attack is terminated in 12 to 24 hours. Even after the control of attack, we have to continue the NSAIDs at a lower dose for 1 to 2 months. The next in the category is colchicine. Now, this is an alkaloid which is obtained from Colchicum autumnale. And there is a very, very peculiar thing about this drug. That is, it is neither analgesic nor anti-inflammatory, but it is specifically suppresses the gouty inflammation. And the mechanism of action is the same way that the NSAIDs were acting in the gout. That is, it inhibits the chemotactic migration of WBC and the subsequent events. So one thing that is that characteristically stands out in this drug is that it is only effective against the gouty inflammation. Now, when you look at the ADRs of this drug, the ADRs are quite unwanted and severe ADRs. You'll have a patient might end up with abdominal cramps and bloody diarrhea. There could be disorders of the blood like the aplastic anemia, agranulocytosis, myopathy, and loss of hair. And because of these notable ADRs, the colchicine is less preferred for an acute attack of gout as compared to NSAIDs. The next category of drugs for acute gout includes the corticosteroids. Now, the corticosteroids are like reserved drugs for refractory cases or those who are not tolerating the NSAIDs or the colchicine. So we usually prefer the intra-articular injections of systemic steroid in the affected joint. Even systemic steroids like prednisolone at the dose of 40 to 60 milligram per day is also prescribed. So that finishes the drugs for acute gout. Now we move on to the drugs for chronic gout. And under that, we first deal with the synthesis inhibitors. So as I already mentioned, the most important synthesis inhibitor is allopurinol. So first we'll have a look at its mechanism of action. So you have to remember that it is a hypoxanthine analog, and it is a substrate as well as inhibitor of xanthine oxidase. So I've just shown here the purine metabolism once again, and I've also included the allopurinol metabolism here. So I mentioned that it is a substrate as well as an inhibitor of xanthine oxidase. So it means that it inhibits the xanthine oxidase. So when it is inhibiting the xanthine oxidase, what happens is that you have a decrease in the production of uric acid. On the other hand, the levels of hypoxanthine and xanthine are increased because they are not metabolized to uric acid because the xanthine oxidase has been inhibited by the allopurinol. As a result, you have a decreased level of uric acid and you have the hypoxanthine and xanthine levels becoming high. However, the hypoxanthine and xanthine are both soluble in water and they are excreted very easily through the urine. Now, being a substrate also of xanthine oxidase, allopurinol is acted upon by xanthine oxidase to form the product alloxanthine, which in turn will inhibit the xanthine oxidase. So because of this mechanism, allopurinol is able to decrease the production of uric acid very effectively. Now, when we come to the ADRs of this allopurinol, hypersensitivity reactions are the most notable reactions that are seen with the use of allopurinol. However, one good thing is that it subsides on stopping the drug. Very rarely, some patients can develop a Stevens-Johnson syndrome. So the contraindications, obviously, for the use of this drug are patients who might develop, who are hypersensitive, pregnancy, and lactation. It can be used in elderly, children, kidney and liver disease, but with caution. Now, it is also good to remember some drug interactions of allopurinol. It inhibits the degradation of anti-cancer drugs like mercaptopurine and azathioprine. So when you're giving allopurinol along with these drugs, the levels of mercaptopurine and azathioprine will be higher because the metabolism of these drugs are inhibited by allopurinol. It also inhibits the metabolism of the anticoagulant drug warfarin. So the uses of this drug, it is the first choice drug in chronic gout. It is also used in secondary hyperuricemia. And another use of this drug is to potentiate the action of 6-mercaptopurine and azathioprine. Now, the other synthesis inhibitors includes febuxostat. It's also a non-purine inhibitor of xanthine oxidase, and it is equal or more effective than allopurinol in lowering the blood uric acid levels. The notable toxicity seen with febuxostat is hepatotoxicity, and so LFT monitoring is advisable at regular intervals if a patient is put on febuxostat. So this is often considered as an alternative to allopurinol, especially in patients who are not tolerating allopurinol or in patients where there is a contraindication to the use of allopurinol. The next drug under synthesis inhibitors is rasburicase, and it is a recombinant urate oxidase enzyme. Now, urate oxidase is an enzyme that oxidizes the uric acid into soluble and easily excreted forms. So, this being a recombinant urate oxidase enzyme, this one will oxidize the uric acid into more soluble forms which are excreted in the urine. Now, the indication for the use of rasburicase includes only secondary hyperuricemia, that is the chemotherapy-induced hyperuricemia in patients with leukemia. Now we come to discuss the uricosuric drugs, and in this, the most important drug is probenecid. Now, this is an organic acid, and this drug inhibits the renal tubular reabsorption of uric acid by blocking the OATP transporter on the renal tubules. So you have already been familiar with the transporters from your general pharmacology classes. So you have a transporter which is called as the organic anion transporter on the renal tubules. And the characteristic feature of this transporter is that it reabsorbs the products of the body. For example, the uric acid, something which is produced by the body, and it tends to secrete out the xenobiotics or something that is foreign to the body. So this transporter, when it is inhibited, its normal function is inhibited, it will inhibit the tubular reabsorption of uric acid. And at the same time, when it is inhibited, it will help in the reabsorption of xenobiotics. Now, for the same reason, this drug can be used to inhibit the tubular secretion of penicillin, or in other words, when it is inhibited, it will increase the reabsorption of penicillin and cephalosporin, and hence it can be used along with penicillin and cephalosporin to prolong their action. Now, this drug is very well tolerated, and only occasional dyspepsia is seen in some patients. So this you have to remember. It is not only used as a second-line drug in chronic gout, it is often used to prolong the action of penicillin and cephalosporin. And it is also a favorite question of examiners to ask you the rationale why probenecid is added along with penicillin. So the answer is that when probenecid is added to penicillin or cephalosporin, it inhibits the OATP transporter, and thus it inhibits the tubular secretion of penicillin and cephalosporin, which prolongs the action of penicillin or cephalosporin. Now, with that, we have almost come to the end of this topic. There is one more drug, that is sulfenpyrazone, which is also a uricosuric drug, but it is not a very popular drug because of gastric irritations and other side effects. So we principally have the probenecid as a main uricosuric drug. Now, a slide about the important aspects of drug therapy. So always remember that acute attacks are managed first with the help of NSAIDs, colchicine or corticosteroids if it is not responding to NSAIDs and colchicine. And these drugs, NSAIDs in particular, are started with a high dose and they are continued at a lower dose for a few months before the drugs for chronic gout take their action. Now, when it comes to the comparing between synthesis inhibitors and uricosurics, synthesis inhibitors are preferred first, and the uricosurics are the second line of drug in chronic gout. So whenever a patient is treated for gout, make sure that he takes liberal fluid intake during the therapy. So that's all for this class. Thank you all for your patient hearing.